Welcome back, everyone. We would now like to move on to our second case. Patient details. An 80-year-old male with no known comorbidities with a diagnosis of queric carcinoma of head of pancreas. An 80-year-old gentleman presented with complaints of abdominal pain for past 2 weeks. The pain was sudden in onset. It was dull aching type of pain with no specific aggravating or relieving factors. There was no history of radiation or migration of pain. Patient also complained of yellowish discoloration of eyes and passing high colored urine for 4 days. History of loss of weight was present, and he was a chronic alcoholic for past 40 years with the last binge 1 month back. Patient is not a smoker. Examination wise, per abdomen was soft and non-tender, and a 3 x 2 centimeter swelling was palpable in the right hypochondriac region. Bowel sounds were present, and a midline laparotomy scar was present. PR wise, clay colored stools were noted, and there was no growth. Investigation wise, urea creat was 37 and 1.08, sodium was 137, potassium 4.1. Bilirubin was raised, total bilirubin was 17.2 and direct bilirubin was 10.6. Liver enzymes, AST was 82, ALT 149, ALP 447, GGT 409. Counts were 10,340, hemoglobin 12.6 and platelet 3.4 lakh. Tumor markers, CEA was 6 and CA99 was elevated, was 19,330. CECT was done for the patient. CECT wise, bilateral IHBRD was noted. There was choledocholithiasis and a hypodense lesion in the head of the pancreas was noted, and a large right renal cyst was also present.
Uh, Vishal, it's over here. We can start with the introduction of the members or the staff in the OT. Yeah, cameraman, to focus on the people who are being introduced.
No. Hello. Now we'll just introduce all the members who are involved in this workshop.
Hello. Vishal, can we have the camera person focusing on the person which we are whom we are introducing over here? Vishal, are we ready?
Yes, sir.
Yeah.
So from anesthesia side, we have under guidance of Sumanlata ma'am, Deepak sir, SR, Adarsh, Fatima, JR, and from anesthesia side, from sister, who all are there, brother? Your name? Anand brother? Nityanand brother? Preeti sister? Okay, and technician Gopi ji? Okay, and Hema madam is also there. Okay, anyone? From endoscopy room, we have Padma sister, yes, and Silvamati sister.
From that team, anyone? They can introduce themselves.
Like your name? If you want to introduce.
So now we will go to the next case, I think.
Yes, sir. Yes. Sir.
I think they would have introduced the, would have listened to the history. And we have our people actually. I think you would have seen in the last case. He's my technician, senior technician from Global Clinicals, Mr. Lohanathan. And she's Farnas from Boston Scientific. And we have Vijay Kumar from Olympus. So, and we have other people from ERCP also. I think they are not there. So now we are going to the next case. I think you would have listened to the history. He's an 80-year-old male with pancreatic head malignancy with biliary obstruction. And when you look at the image, the bile duct is grossly dilated, and there are incidentally picked up stones within the bile duct. And the main indication is now, usually when the patient is having a distal malignant biliary obstruction, the patient is operable. Generally, they'll go for straight away Whipple's procedure when the patient is operable and there are no vessels are involved and no distant metastasis. The best option should be a surgical cure for the Whipple's. And when the bilirubin, sometimes when the bilirubin is high, sometimes they'll ask the surgeons to keep the bilirubin under less than 7 or 5, so that the patient will be better to have a better post-operative morbidity, and so that we may go. Or the second indication, patient is in cholangitis. In this particular case, patient had a suspected cholangitis. That's the main indication. The idea of doing ERCP in this case to just to drain the biliary system, not to remove the stones, because there are expected biliary narrow stricture just in the supraduodenal portion of the pancreatic bile duct. So I'll be demonstrating the case as the case goes, and once again I'll show you how to intubate again, and what are the steps involved in the cannulation of the selective cannulation of the bile duct. And this case we may expect to have some difficulty. Those cases with distal malignant biliary obstruction will have very difficult to pass the guide wire. Sometimes it may be easy to pass. Sometimes we may need to use a precut sphincterotomy to access the bile duct. So as the case goes, then we'll see how it goes. And now we are going to start. Are we ready? Yeah. Sheet. And take the wire out. Okay, sir. Yeah, okay. Thank you. Okay. Can we start? Okay, so now we are going to start. I'm going to intubate the scope. In the as like we have seen that how we are going to intubate in the last case. Now patient is in prone position. Patient is intubated, and now my assistant will help me to intubate the scope. Actually, he has to lift the right shoulder, so that it will be more like a left lateral. So I'll pass my scope just in the posterior part of the tongue. Now this case is much easier and easier. You can see. I'll show you that.
Can we have the endoscopic view?
Yeah, can we have an endoscopic? Can we have endoscopic view?
With picture-in-picture outside view also?
Are you able to see?
Yeah. Yes, sir, we are able to see.
Yeah, so you can see the endotracheal tube and epiglottis is there. But generally we don't see, because scope is what I did actually. I did a big wheel down so that I can able to see. But With that scope position, you cannot intubate. So I keep the scope position neutral. I'll torque my scope to one of the pyriform fossa and slide little bit of air insufflation, and I'll go inside. So now I am into the esophagus. You can leave the shoulder, you can cover the patient. So what I'm going to do is I'm just put a little bit of air so that I'll inflate the esophagus. So you can see now big wheel down. So it's like you can, like an upper G endoscope, you can see half of the esophagus. I'm passing my scope down. Can you able to see, appreciate that? So you can see the gastroesophageal junction. The stomach is distended. So I'll suck, there no fluid is there. Stomach is completely empty. As you enter, you can just watch the outer camera. So how I am standing till I reach the stomach. So you can see that scope is in a neutral position, which is parallel to the esophagus.
External view, little zoom out.
Yeah, just zoom out. See how I'm holding my scope. Till I reach the stomach, my scope position is this.
No, that scope position and all these things is not visualized, sir.
Not visualized.
Because that the
Can you
camera
just
person should take care of it.
Can you just focus on my hand, scope, and patient position?
Can you
Just
make,
little
remove
down.
the PIP and show the external camera view alone?
You can zoom out. You can. Is that okay? Can you able to see?
No, sir, that exactly the
you
wheel
have-
movements
you have
and
to
the scope handling is not visualized.
Is it? No, this is the best. Can you able to see now? You have to focus
Can
this.
the external
the
camera
whole-
be zoomed out?
No, the whole thing. You have to go back. You have to go back.
Zoom out. And change this PIP to a single picture of external camera view.
Are you convinced?
Yes, sir.
Yeah, okay, fine.
Mm.
So this is how it, I'll face towards the patient till I reach the stomach. Okay. So now what I'll do, I'll just turn a external camera, focus on my body movements. Just focus on my shoulders, or you can come this side. You can see. You can just move this side. To go back, show me. So what I'm going to do is I just inflate the stomach. I turn my body more right. Okay, now you can change the endoscopy view with the PNP, PIP. Do you get the endoscopy image?
Yes, endoscopy image is fine.
Okay. So what I'll do actually, like from here onwards, I'll push my scope. Like what I can do, now the camera can focus my hands. So I'll keep the big wheel down. So keep the big wheel down like so you can use it like side wing scoop into a forward wing scoop. So big wheel down. As I push my scope deep inside the stomach. So big wheel down so that now you can change over to the endoscopic view. There is some deformity in the antrum. So this is not a normal stomach. So what I'll do, I'll just push my scope more and more to reach the pylorus. I could not see the pylorus like a last case. So now I enter into the first part of the duodenum. Can you able to see, visualize?
Yes.
Yeah, so there is some bit of narrowing is there in the first part of the duodenum. I'm not sure. These kind of a cases, when there is a doubt on imaging in the CT, ideally to have an upper G endoscope so that you don't inadvertently cause any injuries. So I anticipate some problem. So there is some narrowing in the first part. We crossed it. And I'll try to push my scope inside. There is some narrowing is there. This kind of a case is preferred to have an upper GI. Can we have an upper GI scope? So we are there in the first part of the duodenum. There is a bulge. Just wipe it hold.
External view, please focus on the endoscope and this.
So I'm unable to interpret the D1, D2 junction. My scope, I'm in a very long scope position. I'm trying to negotiate the D1, D2 area. So I think there is some narrowing is there. So I don't want to try this. Let me check with an upper GA scope. I'll just come out. Okay.
There was difficulty negotiating.
Just want to see sometimes we'll have an idea like what is the big, there is D1, D2 entry is much narrowed.
Yeah, but
and
could enter.
able to enter. Okay. Now sometimes we have an idea, roadmap just before the duodenoscope. Sometimes we'll have cases like there is narrowing in D1, D2 junction due to peptic stricture. We dilate, we'll have a mental roadmap with a forward being scope that where to turn, where to, because side being will have a different orientation with the forward being. So always we'll have an upper GA scope. So now what I'm doing is, what I'm going to do is, I'm taking out my duodenoscope and going to interpret with the forward wing scope and just have an idea like what is going on. So this kind of cases, sometimes there may be narrowing. We may expect some narrowing due to benign or a malignant etiology. Sometimes we'll have most common problem is a peptic ulcer disease. There may be narrowing due to peptic ulcer disease. That's due to benign etiology. Sometimes malignancy. It's very rarely periampullary growth is an advanced growth can cause duodenal narrowing, or GB malignancy or even duodenal malignancy per se can cause D1, D2 narrowing. So whenever there is a history of gastric outlet obstruction, in this case, actually stomach is empty. So I don't think any big stasis is there actually, but still I want to know what is happening in the D1, D2 junction. I'm going to use a forward wing scope, see what is going on, then we'll proceed. And in case if I'm unable to negotiate with the duodenoscope, the only way to reduce the, relieve the biliary obstruction only with the PTPD. So percutaneous biliary drainage, that's the only way. Whenever there is a biliary obstruction where we are unable to do an endoscopically, we are unable to relieve, PTPD is the only way. There are, in case we have an endoscopic ultrasound, in case the patient is a palliative care. So what we do, EUS guided choledochoduodenostomy, we can just put a metal stent, covered metal stent across the duodenum and the distal part of the bile duct. Or rarely, in case of palliative setting, we do a hepaticogastrostomy also, EUS guided. And this is all for a palliative setting. If a patient is going for a Whipple's, even still you can do a choledochoduodenostomy without much of an IR guided interventions. So we manage endoscopically. So now I'm going to use a forward wing scope to go inside and see. Power is not good. That's come. So I think you must be having an endoscopic view. You have a white balance. Yeah. I'm just inflating the stomach. When the distal stomach and antrum is deformed, sometimes it happens that we are unable to identify the pylorus because of insufficient insufflation and poor quality images. And just give some water for flush. Yeah, it's okay. No insufflation. You're unable to say anything. Insufflation is not happening. Water, get the waters. Get a bowl. No, yeah, very minimal. Some inflation is there.
Sir, any technical difficulty there, sir?
Yeah. Some technical difficulty with the scopes. We are not getting enough inflation so that we are unable to find the pylorus. It may happen that.
Yes, sir.
I think we are entering into the. It's like duodenum. It's the pylorus. This is probably a gallbladder. Can you just wash? You can just give a wash. You can see that there are some narrowing.
Yes.
This is the D1, D2 junction. I'm passing the scope. It's well up. So we are able to enter, but it's completely deformed.
Yes, sir.
So let us try once with the duodenoscope. In case if it is not going, we will not try much. We'll give it to the radiologist so that they'll do a better job rather than creating a complications. So I'll have a roadmap. So from here onwards, I'd use go big wheel up. Even with the forwarding scope, I'm unable to see anything. So
Yes,
I
sir.
have to push up. It is in the top here. Then I have to turn more right. So I'll come back. Let me try. We use Olympus system. We are not very familiar with the Pentax, but I use my personally earlier days, we used Pentax actually. Both will have different optics, imaging qualities. So already I'm in stomach. What you can do, you can lift the patient to left lateral, so we can sometimes can move the machine, lift the patient more left lateral, so that we can. Sometimes when patient in prone, it's always this difficulty comes. Even intubating the pylorus will be a difficult. So that's why left lateral is always a good option. Can loosen this belt. Yeah, can lift.
Any other indications for left lateral position, sir?
No, generally we prefer left lateral because it's much easy to intubate the pylorus.
What about the fluoroscopic images?
No, I mean for initial intubation, not for the
Okay.
entire procedure.
Okay.
Sometimes we do procedure on left lateral itself. We'll complete the entire procedure in left lateral. Now you can see that actually on left lateral portion is holding the patient in slightly on left lateral. You can see the pylorus and other, I mean, no, I have antrum in a better view. And push my scope. I think if everything is completely deformed. This kind of a difficulty we most often anticipated in patients with malignant obstruction, post-transplant. There won't be any left lobe. You can see now. Now the pylorus is just between this fold. It happens. Now we are into the first part.
Yes.
The real challenge is here. So now we are into the D1, D2 junction.
Yes.
I have to go up, more up. But now you can see that it's kind of a retroverted in the first part of the duodenum. So
Yes,
you
sir.
can see. But you should be very careful. Duodenal wall is very thin. The whole area is deformed. Scope is not going in the right way. So you can see the right Lower corner is the way you have to go.
Yes.
Just pushing the scope may not help sometimes. Can just give a pressure and abdominal pressure. Can leave the patient. So we are just on the way. Yeah, let's try it. Yeah.
Mhm.
We cross that narrowing, but we are still unable to go into the way we want.
Mhm.
So we got the papilla somehow.
Yes, yes.
Sometime in live demonstration, we get a real difficult cases to assess our technical skills.
Once you reach the near the papilla, you visualize the papilla. How will you stabilize the scope, sir?
So generally, patient in prone, I keep the, always keep myself on towards the right. That's the best way to keep the scope stabilized. Look at my hand actually in the external camera, I can focus.
Yes, yes,
So always my scope will be like towards more on a clockwise rotation.
yes.
If I drop my scope this way, I will fall. If
Okay.
I drop this way, this is my limitation.
Yes.
I turn more and more.
Mhm.
So I'll adjust consciously, and even without my knowledge, I'll always keep my scope like this. My hands always will be irrespective. I turn this way, whatever way I turn, my hands will be always like this. This is the best way to hold the scope in position. So when scope is unstable, turn more right.
Yes.
So here you can see the papilla. So I'll just push the folds down. You can see that this is the frenulum, not like a regular case, no last case. It's just more flat. So here we can see the papillary mold. This is the duodenal wall. So here till here is the suprapancreatic portion of the, intraduodenal portion of the bile duct comes. Here is a fold till here. So now we'll try to cannulate. So I generally always be little away from the papilla so that I can bend my cannula. Can you just keep the wire little out? Little more in, yeah. So again, I'll go and touch the papilla at 11 o'clock here. So here, then I'll wait. Let me engage the papilla first. Yeah, now I engage. I'll ask my assistant to do little bend so that it will go in the right direction. So now I don't know whether I'm there in the bile duct or the pancreatic duct. Even either of the duct, just cannulating either duct is fine. What I'll do actually, I'll wait, just you can try to, I have a feel that probably I'm in pancreatic duct. So you want to have a CM? Rotate. It's not rotating. Yeah, rotate. I'll tell you when to stop. Rotate, fully rotate. The camera can focus the fluoroscopy. Yeah, stop it. Can you have a mirror image or? Yeah, fine. So now we have a better image. So always the scope should be at 6 o'clock. You can just move the scope little. Just relax everything. Yeah, fine. This is perfect. Now I told you, no. Now you can see the wire is cross the spine.
Yes, yes.
Now it's in the pancreatic duct. This is the gut feel actually because we are not properly oriented.
Yeah.
So my technician has placed a wire. So now what I'll do actually, I'll pull back the wire completely, or I can do either one. What I can do actually, I'll pull back my cannula, keep the wire in position so that I'm still within the papilla, slightly away. Now you bow, bend the sphincterdome. No, without removing the wire, bend the sphincterdome more. So keep my axis more bowing. Yeah. So now I'll ask my technician to pull the wire and pull the wire completely. Bow more. No, this will go again to the PD. Bow and try. Now try. Try. If you have any resistance, you tell me. Again, you are going to the PD probably. PD. This is again a PD.
Yes.
What I can show you, like when this kind of a cases for a demonstration purpose, what I'll do, I'll a double wire technique. So I'll push my cannula in, unbow, release the bow. I'll go deep. So I'll exchange a wire because this wire may not be sufficient for a double wire technique. What I'll keep one wire inside in the pancreatic duct so that it will stabilize my papilla. Generally, in difficult cases, we do this technique. This for a demonstration purpose. Otherwise, I can pull the wire out. I can try some other methods like, I can try once again to cannulating the bile duct, or I can do a pre-cut sphincterotomy or papillotomy so that I can access the bile duct straight away. So here I just pass the guide wire twice into the pancreatic duct. So for the demonstration purpose, I'm just showing how we can use a double wire technique, keep the wire in the pancreatic duct, then cannulate. So now wire is there inside. Can you see in the fluoroscopy like wire in the pancreatic duct? I'll exchange now. You just tell me if you have any difficulty in visualizing the images.
No, the
Wire is
fluoroscopic images will visualize, sir.
well visualized. Okay.
Yes,
So
yes.
it is there in the
Able to
pancreatic.
see this guide wire into the pancreatic
Yeah,
duct.
okay. Generally, elderly people tolerate better. They don't, especially malignancies, they don't develop pancreatitis. This is observation we see in most of our patients. High risk patients are all young females, normal duct, normal bilirubin. So these are the groups have high risk pancreatitis. Here we have a dilated duct, elderly male. Even I'm not sure whether the PD is also dilated due to pancreatic head mass. So these patients are less likely to develop pancreatitis. Still, we'll watchful on these patients. We take what are the precautions, what we do for generally for other patients with high risk for pancreatitis. Here we have not manipulated anything much in the pancreatic duct, so the chances are very less. If you work in the pancreatic duct for a long period or inject a contrast into the pancreatic duct, there is a risk of pancreatitis. So here what we are going to do is, one wire is there in the pancreatic duct. What I'm going to do, I'm going to cannulate the bile duct along the side of the guide wire. So this technique will really helpful, especially when the papilla is intradiverticular or along the peridiverticular, around the side of the diverticulum, the cannula, when the papilla is there. So even the wire goes, then we leave the wire there, and along the side we cannulate. I'll show you how we are cannulating. You get the cannula so that.
You told that for the CBD cannulation, you will go from below upwards.
Yeah.
So if we want to selectively cannulate the pancreatic duct, any specific scope position and
for a pancreatic duct, you need to be like short scope position. So that will be much better. Now my guide wire is there. Another cannula has come. Do you get the endoscopic image?
Yes, yes.
Okay, so along the side of the guide wire, now I'll ask my assistant to push the wire out, little out. Yeah, fine. So now I am going along the wire again at 11 o'clock. Once I go inside, so keep the wire little out, wire out. So now my cannula is in. Okay, now I will not be in a hurry to do anything. First I'll do I'll just under the fluoroscopic image. Can you just move the screen this way? Boils, you can just move it. Yeah, much better. Yeah, okay, fine. So what I'll do, can you see that both the wires and the cannula?
A fluoroscopic image little
fluoro-
lower, they can focus lower.
Little lower.
Yes.
Yeah, so don't put the wire. So what I'll do actually right now, so I'll keep the cannula slightly at the tip. I'll ask my assistant to do a bowing so that it'll go a little up. Okay, so now I'll ask my assistant to bow and bow more and more, completely bow. Now I'll ask him to try with the guide wire. Try. Again, wire is going to the pancreatic duct. So I'll change my technique. I'll just pull the wire sphincterotome again. Little unbow. Sometimes the papilla is twisted. It will always go into the pancreatic duct. Now you do bow. So I'll do a little change angulation. Now you can try. Gently try. Again, we are going into the pancreatic duct. So this is what we anticipated, because sometime the bile duct is completely maybe blocked. Now you can see the pancreatic juice is coming freely.
PIP endoscope view can be.
Make the endoscopic view be
Yes,
bigger.
yes. Yes, it is.
So wire is there, you can see. I'll go here, I'll do bow, complete bowing. Yeah, so I'll change the axis a bit. Can try. Bowing may not be very satisfactory. Yeah, try. You're going again and again. So there are other options. One is you can put a stent in the pancreatic duct, do a sphincterotomy. These are the options are there. Let me try once again, then otherwise I'll go a pre-cut sphincterotomy. Because there's no point in drying too much. I'll just go a little down, bow now. Bow. We are well above the papillary opening. Now you can try. Again, PD. So we don't want to do anything. So I'll come back. I'll do a pre-cut, unbow. Get a needle knife. Here the papilla is not in normal position. You can see the frenulum is it's going and twisted. That's the reason why we are not getting the proper axis. Probably the papilla and bile duct is axis this way. Papilla is lying flat. Even the pre-cut also may not be very good. Let me check in a long scope position. So you can just give the sphincterotome. I'll try once again. Now, give me a sphincterotome once again. I'll try. This is a long scope position. If I use a fluoroscopy, you can see the scope position. Can you see the scope? Fluoroscopy, you can focus.
No, sir. Yeah.
Yeah, this is a long scope
Yes,
position. And normally we do it imaging most of the procedure in a semi-long. This is the normal position. This is a semi-long position. In case any difficulty is there, what we do is in a long scope. This is a long scope. You got it?
Yes, sir.
Sphincterotome. So my guide wire is on the way. I'll ask my assistant to keep the guide wire little out. So the guide wire is interfering my cannula position. So I'll push my guide wire little. Bow. Now I'm inside the more bow. Ask someone to hold the bow. Yeah. So now I'm fully into the long scope position. Let us see. Try. Sometimes same, looks like same. Okay. So let me try once again. I'll pull the wire out. We try once again. Sometimes because of the growth, it will prevent the wire to go into the bile duct because it's a very tight narrowing. Probably if you have seen the CT, it's going repeatedly into the pancreatic duct. We are not accessing the bile duct. So I'll just take the wires out. I'll use a needle knife.
Can we have endoscopy view?
Yeah, I'll just give you the endoscopic image. You can see the papilla is not straight. It's just flat. Frenulum is on the sides. This is lying in a flat on the sides. This is the needle knife sphincterotome. I want to see what is a papillary opening. Where is a papillary opening? Its opening is over here. And the frenulum is down, is here. So then my bile duct direction should be somewhere here, this area. So can you keep the needle out? Pull the wire in. Lens is not very clear. So I'm going to do a pre-cut sphincterotomy. Wire in. Wire in. Yeah. Connect to the cable. Ready? Ready? So now we are going to start the pre-cut. Make sure that your needle is not too much in or out. Wire is in, put the needle out. There are many ways to do pre-cut. I start from above downwards. Needle out. Sometimes needle goes out, goes in automatically. Yeah, now it's out. You need to have a good image, endoscopic image when you're doing a pre-cut. This is so there is no hurry. So you have to do it slowly. So my elevator is, we have a limited mobility is there. Volumos will have a better elevator control. Too much cut, too less cut is also a trouble. My assistant is washing and this will get a better view. So there's a wire. Let me try over here. No, one push. Hold, hold. So what you're seeing here, this area is a pancreatic duct, most probably. So I try to cannulate it to level. Right. Resistance is that. Okay, right. So I just preloaded with the this thing hydrophilic wire. So I think I need more cut. Pull the wire in and just take the wire out. Cutting wire.
How much is the adequate that pre-cut
Sphincter atom,
needed?
yeah. So normally there is no right answers. Actually, basically we need to see the pancreatic. Here the image is not so good. Actually, it's completely messy. We are normally in the Olympus we'll get a very good image. You have to see the pancreatic duct and bile duct, even the sphincter contractions, everything better. Here we have a little bit of option limit. So normally we have to start seeing this is the pancreatic duct. Normally the bile duct will be slightly above. You should be very careful when you're doing pre-cut. Because of the tumor, sometimes we may not be able to go inside. So I think it's stop. We'll stop here at guide wire.
And apart from the difficult cannulation, what are the other indications for pre-cut?
Yeah, only when the stone is, for example, when the stone is impacted, we are unable to cannulate. So in that case, you can. So I hope we are entered into the bile duct. So you can see, focus on the fluoroscopy, pull the wire in. I'll pull the cannula, push a wire, push this guide wire. It's there into the bile duct probably, or sometimes it may be obstructing. I'll pull my sphincterotome. Image is not so. Yeah, I want more contrast, more brightness. Yeah. Yeah, it's much better. You pull the wire. Sometimes because every time we'll go to sometimes to the gallbladder, it's not going straight. Yeah, it looks like a gallbladder actually. It's not into the pancreatic duct. You're just above the. So we'll pull back. No, I'll come back.
Fluoroscopic image little lower. You can focus lower down.
Just now candidate. Candidate. No. Right. Or you can inject some contrast so that we will be there, we'll verify our question. Or we can change the spectrum also. You can inject some contrast, very little. The duct is visualized.
Yes.
Still we are unable to get the proximal part of the bile duct. Now, right, what you can do, change a guide wire to change the vesiglide. Then we'll exchange with the sphincterotome. Then we can try with the different accessories. Okay. We'll change.
PIP endoscopic view can be.
You can see some pulses coming.
The endoscopic view is not available.
Not available. Can you switch over to the endoscope?
Yes.
Guide. That's right. Blue is not working. Switch on off. Yeah, fine. Can try.
Fluoroscopic view also little.
Yeah. There you can put some more contrast. I'll keep.
Fluoroscopic view little lower part also you can focus.
Inject. So you can see the duct lower end of the bile duct, but the stricture may be very tight. You can see that. Can you able to visualize the bile duct, distal bile duct?
Lower part is not visualized properly.
Can you just inject some more? Inject.
No, that focus should be on the lower part of the fluoroscopic view.
Fluoroscopy, just focus down.
And can you make
Can
it
you
bigger
able-
one?
Can you
Bigger
able?
picture. Fluoro is not available.
Now it's visualized.
Yeah. So can you see that wire is there in the bile duct? Now we are not in the pancreatic duct,
Yes.
but we are unable to see any contrast is going above. So there must be a very tight narrowing there. So one is we can try different guide. This is even a term of this is a vesiglide what we are using. Very thin hydrophilic wire. We'll try once again. Wire is going. Yeah. Now wire is gone. Yeah. Maybe because the whole thing is deformed. Now you can see the whole thing is went up. Can you just focus on slightly on to the right? Move the machine to the right. Contrast, keep the contrast. Then opposite. Do it the other way around. Yeah. Yeah. So, and you can wait a minute. I'll just check my cannula. Yeah. Now you can see the contrast is there in the intrahepatic portion of the bile duct.
Can the camera zoom out a little bit?
Duct is grossly dilated. Just pull the scope little above onto the right.
Fluoroscopic view upper part. Little.
No. Above. You release everything. You just don't lock. Release everything. I can manipulate. Release up and down. Can you see the intrahepatic radicals?
Yes.
Can you just move the mesh? Yeah, fine. Can you see that?
Yes.
Yeah, so now we are there inside the bile duct. Our guide wire is there in the intrahepatic radicals. I mean, it's not, I think if you have seen the CT, the system is hugely dilated. So we don't want to inject too much of contrast. So anyway, what I'll do, I'll aspirate some bile so that I'll make the system little less capacious. Then I can inject some contrast. I'll show you where is the stricture. Can aspirate the bile. So we are getting a white bile, not green. Probably the camera focus. Take the hands. Can you see
Yes,
that?
appreciated, sir.
So it's not a yellow color. Sometimes it'll be dark green. Sometimes it's white bile. Long-standing obstruction. This is 100% malignant biliary obstruction. Because you can see a white bile. There is no bile at, greenish, yellowish color bile. It's long-standing. It's a malignant obstruction. So what we generally do is suck out as much as possible so that we require a less amount of contrast. You don't need so much of contrast as well because you will have a pre-procedural CT imaging. Where is the stricture? What is the size of the duct? Everything. You don't need to have a full cholangiogram to get to know entire size of the bile duct. Anyway, just for a demonstration purpose, we'll put some contrast. So the plan is, here they want bile for culture. Ideally, all case of cholangitis or suspected cholangitis, you need to take a blood culture as well as bile culture to know the culture and sensitivity pattern. Most of the organisms are gram-negative, either E. coli, Klebsiella. These are the most common organisms. They are often sensitive to cephalosporin group in community-acquired cholangitis. Those who are hospital-acquired, they need either a piperacillin tazobactam or carbapenem groups. So this is the empirical antibiotic we start. Here we are aspirating more bile for culture. Doesn't look like infected. It's not turbid. It's very clear. Sometimes we may get some organism maybe growing. Sometimes patient already received antibiotic. We may not get culture positivity.
Sir, what measures do you take during this ERC and cholangiogram to reduce the infection and host of cholangitis?
So most important thing is you have to reduce the ductal pressure. That's a very important thing. You must be knowing that the pericholedochal plexus are very highly vascular around the bile duct, especially in cholangitis. Rise in intraductal pressure per se it increases the chance of cholehepatic reflux. So that very easily infection can enter, then can cause more septicemia. So in case of suspected cholangitis, all cases we aspirate the bile and make sure that reduces the intraductal pressure. Then we do a cholangiogram, or sometimes we may not do cholangiogram at all. I'll keep my catheter down. 1 minute, wait a minute. You can, cholangiogram can focus. Yeah, inject more contrast. I think you can see that we are unable to fill the bile duct. We are just filling the intrahepatic duct. We don't want to inject more contrast I think it will take another 30, 40 ml to contrast to fill the, to get the proper cholangiogram. I don't want to do that. What I'll do actually, I'm going to place a stent. That is my idea. Ideally should be a metal, but here we have multiple stones. Even if you place a metal stent, stone will come and clog the stent. So my idea is to just to dilate, just to push up the stent for a 10 French stent or something. So what I'll do, a balloon dilatation. Hurricane, that is a balloon of choice for dilating the strictures. Biliary stricture balloon dilatation, normally it may not be equivalent to the sphincteroplasty. What we have seen is a CRE balloon, controlled radial expansion balloon for a sphincteroplasty. The size is 12 to 15 mm. For biliary balloon dilation, now I'll exchange with the guide wire. A hurricane balloon at 10 mm is fine. So we are going to use a biliary balloon dilator. Different sizes are available, 4, 6, 8, 10 millimeter balloons, just to dilate the strictures. Here, because even where guide wire was not going, I think you would have seen that initially, only we are able to fill only the distal bile duct. Here, what we are doing is, so in that situation, guide wire goes, sphincterotome goes, but we may not be able to pass the stents, especially a large size stent, 10 French stent may not go. So we'll get stuck. So to avoid that, what I'm going to use a hurricane balloon, that is a biliary balloon dilator from Boston Scientific. So that is, and the difference between the CRE balloon, this is, the balloon is smaller in length. The CRE balloon is 6 centimeter. This balloon is only a 4 centimeter balloon. You can't put a CRE balloon to dilate a biliary stricture. It causes rupture of the bile duct. So hurricane balloon is a biliary balloon dilator, which I'm going to use. I'm using a 10 millimeter hurricane balloon just to dilate the malignant stricture to accommodate the stent. So what I'm using, you can see the fluoroscopic image when the camera can focus. I'll just push the balloon. You can see two markers. Can you able to see? Above and below the scope, there are two markers.
Can you maximize the fluoroscopy image?
Yeah. Just focus on the lower part. Can you able to see the fluoroscopic image?
This PAP can be changed to fluoroscopy image.
PAP can switch over to fluoroscopy. Have you got it?
Not yet, sir.
Can you switch over the fluoroscopy? Image? Have you got the image? Not yet?
Not yet. Yes, sir, we got it.
You got it?
Yes, sir.
So now you can see that just below and above the scope, you can see two markers.
Yes, sir.
That is the upper and lower end of the hurricane balloon.
Yes.
Now I'm going to dilate. I'm just using a fluoroscopy. My assistant will put a contrast filled balloon. You can just dilate.
Sir, how do you know that balloon is in point of interest?
Yeah. That's a good question. Sometimes deflate. Now, ideally, if you put a contrast, you know that where is the stricture. Here we are unable to see. Even I put a balloon is slipped down. Now I know that there is a stricture is even more above. So I'll push my catheter traction. So now I'll go a little above. So I'll go a little above so that I can come down. The balloon position is little up. Now what I'll do, I'll ask my assistant to inflate the balloon now. Now you can see, now balloon is going up.
Yes.
So it is, the stricture is there just above just below the balloon. Now just deflate a bit. So I'll bring it down. So you can see the narrowing now. Can you see the narrowing? Yes. So now I'll keep the balloon down. I'll ask my assistant to inflate slowly
Okay. Okay.
so that you can you see that?
Yes, now we
Yeah,
could see
now
the
you can
disk
see?
formation.
Yeah. So I'll just change the scope position so that you can see better. Can you see the image now better? So
Can this fluoroscopy be on the bigger size?
Can you see
The
that?
fluoroscopy can be maximum.
Fluoroscopy maximize.
Yes, sir.
Can you see the narrowing? That balloon
Very
is on.
nicely.
Yeah, you can see the nice waist. So I'll ask him to inflate more so that the waist will slowly disappear. Sometimes we may not aim to complete it distant the stricture. Just to accommodate 10 French tent is more than sufficient.
So how we decide the dilatation?
Yeah, the balloon is size is 10 millimeter. 10,
Yes.
10 French stent is almost 10 divided by 3. That is the size of the stent actually. So even 3 French stent will accommodate so that it can go. 10 French stent will go.
Oh.
So I think we have come out.
For how long we will wait for the stricture dilatation? Sir? Any
Just
time?
10 to 20 seconds.
Yeah.
Okay, stent. Logo. Scope. We are coming out. Right, we are coming out. Wait. It just got slipped out. I'm just repositioning my scope. So now the balloon is completely deflated. I'm going to exchange. Can deflate completely. Some more. Have you got the endoscopic image?
Yes, sir.
So my guide wire will be in place, exchanging the balloon. So this is the wire which I am using is a Visic Glide. You can see that alternative markings, stripes. You can see black and white stripes, so that we can see if any movement of the guide wire without using the fluoroscopy. So I'm going to use a 10 French stent. So that will come for long patency. It has a little longer patency. Ideally should be in a given choice, I would like to place an uncovered stent because bile duct is fat. We have a gallbladder. So I would prefer to have a uncovered biliary metal stent. And then within that, I would like to place a plastic stent because in the image, I could see a lot of stones that will come and block the uncovered metal stent. Or other option could be placing multiple plastic. The only issue is there is a stricture. Sometime we may not be able to place multiple stents. After placing one stent, the other stent may not go. So now I'm just going to place a 10 French stent, 12 centimeter. So this is the where you can focus. This is the pusher. What we are using is a Oasis. Probably you must be knowing that. So in that, actually, there will be a guiding catheter. This is not the stent. What you're seeing in the endoscopically, it's a guiding catheter. You can see the marks. If I put a fluoroscopy, you can see the 3 marks will be there. I'll just push more. Can you see 3 marks? You can just focus on the fluoroscopy. This is the Oasis. One action stent introduction system. This in a single instrument, you can load the stent and the guiding catheter over there. Can you able to see that?
Yes, sir, we can see.
So once Oasis is in place, now I'll ask my assistant to release the sheet. Now the stent will come. It will go over the guiding catheter, not over the guide wire. So the one, without changing anything, you can do it in a single way. That I could able to see some resistance, as I said earlier. I need to push it little. So give him more traction. Wait. So again, I told you the same place we have a difficulty. Hold like this. Hold with the torque. Now, traction. Stent has gone up. So now you can see that the stent is there. I'll just verify again. Stent is there well above the stricture. I'll release the stent. Yeah. Now you take the stent out. Now you can see the bile. White bile is coming. Can you able to appreciate that white bile?
Can we have the endoscopic?
Endoscopic image, please. Endoscopic image. Got it? Have you
Yes,
got?
sir.
So you
Yes,
can see the white bile which is flowing. You got it?
Yes, sir. Yes. Sir.
Okay, fine. So this is the end of the procedure. Now we just place a stent, plastic stent to drain the biliary system. So the contrast, everything will drain through this. You can see the plastic stent well above the stricture.
Oh,
So now I'll conclude the second case. I'll suck the stomach. The real challenge was there are two steps. One is just accessing the papilla. Another difficulty is cannulating the bile duct because it is very tight, narrowing. So now we are able to place it. I'll do one more imaging.
It was nice demonstration, sir, with
Okay. Thank you.
3 difficulties in the procedure. What in case of some post-operative cases with GJ?
Yeah.
Uh,
Post GJ. Yeah,
yes.
we have a short double balloon. So even for a short front limb, we can use an duodenoscope. So in case HepJ or when the front limb is long, we have a short double balloon. So through that we can access the papilla. Then you can place a stent or you can do endotherapy. That is possible with the altered anatomy. Even post Whipple's, even post hepatic jejunostomy or GJ with altered anatomies, we can able to access the bile duct because of the short double balloon. Because we don't have an accessories for a small bowel accessories because it is 200 centimeters scope length. We don't have accessory for that. So we use a short double balloon nowadays, which is available even with Olympus, even from Fujinon. They have a short double balloon we can access. We have done cases also.
You mentioned about one choledochoduodenostomy.
Yeah.
So how frequently you do it?
Usually for a palliative intent, actually, when patient is a distal malignant biliary obstruction, and when you are unable to access the bile duct, sometimes failed ERCPs, or when the papilla is completely replaced by the mass or a tumor, D1 is always preserved most of the time. So we can access the bile duct from the first part of the duodenum with the endoscopic ultrasound. Then we use either a hot oxyas, that is the stent which is nowadays available. We can directly puncture this cautery assisted device. So the stent is loaded on a cauterized device where you can directly puncture the bile duct, visualize in a avascular plane from the duodenum to the bile duct. This is meant for distal malignant biliary obstruction, not for the proximal. And in case choledochoduodenostomy is not possible, we can, if the gallbladder is intact, even we can do cholecystoduodenostomy or cholecystogastrostomy. This also we do actually. When the bile duct is, when a lot of vascularity around the bile duct, still we want to do palliative care just to drain the biliary system. Even studies showed that cholecysto drain the gallbladder into the first part of the duodenum or into the antrum. That is as good as any surgical or intervention data. The purpose is same. We are going to drain the gallbladder or the bile duct. This we do it on regular basis.
Okay, sir. I think the delegate must be having some questions.
Yeah.
Today we have a third case, which is a choledocholidiasis.
Some delegates want to ask some questions.
Yeah, okay, okay.
Sir, at what rate do we inject the contrast so that to prevent the risk of pancreatitis? Rate of means contrast, is there any?
Yeah, ideally, it's a good question actually. When you are injecting, for example, when you are not very sure, even like this case, we're not very sure it's a bile duct or a pancreatic duct. Ideally, if your technician is good enough, you are working with her at least 5-10 years, you know that actually, there is no rate. We can't measure the rate of infusion, but it should be very gentle, slow injection, just to fill the system. Sometimes when we inject contrast, if you forcefully inject, you don't use a force, gently inject the contrast, just fill the system, then we know that whether we are in the bile duct or a pancreatic duct. And the most important, when you inject force, then you get an acinerization, that where you will fill the side ducts also. That is very bad. That's the reason when the assistant is new, then you should not allow them to put a contrast. You take the catheter, you inject the contrast slowly so that it fills the pancreatic duct, not to just acinerization, that it's increase the risk of pancreatitis. It's a very good question. But there is no rate as such. We don't have any system to push, like a CT scan, you just put the system, this flow rate and this, so that's, pump will deliver the contrast. That since it's human beings are injecting, there is no rate we can adjust. But most important, slow filling. That's very important. It's a good question.
Thank you.
Any questions from the audience?
Good afternoon, sir.
Good afternoon.
Postgraduate, sir.
Yeah.
Can you please show me the instruments and that sphincterotome, needle knife sphincterotome, all these? Can you please show me?
Yeah, I think they took away for the washing, and probably maybe then before the next case, we have another case, CBD stone. Before starting that case, I'll show you each instruments.
Okay, sir. Thank you, sir.
Okay, thank you.
Hello, sir. We are able to hear you, sir.
Yeah, we have a third case, which is a patient having choledocholithiasis. That will take about 5 to 10 minutes. So meanwhile, we will have a quick short lunch break. The delegates also can have a short lunch break. I think working lunch is served in boxes. So
saying that we'll finish it.
No, sorry, shifting.
By the time we can finish.
Yeah, we can finish it. Okay, thank you very much.
1:15